Okay, we are already online, doctor.
Okay.
Muy buenas tardes a todos. Es para mí un honor continuar con la programación del día de hoy a nombre del señor embajador de la UNESCO, Jorge Herrera Ramos, quien es chairman de este World Congress, the World of Neurosurgery in Your Fingertips, a quien agradecemos enormemente por la organización de este magno evento. Igualmente agradecemos a la doctora Deyanira Capi Casillas, quien es chairman de ANS IPN, al doctor Salim Abdul-Raouf, quien es chairman de Walter Irandi Neurosurgical Society, al Dr. Babak Katef, chairman de la Society of Brain Mapping and Therapeutics, y al Dr. Parmenides Guadarrama Ortiz, quien es chairman del Centro Especializado de Neurocirugía y Neurociencias México. Es para mí un honor y me complace muchísimo presentarles a nuestro siguiente ponente, el Dr. James K. Liu.
Good morning. On behalf of Mr. Jorge Herrera Ramos, UNESCO Ambassador and Chairman of the World Congress, the World of Neurosurgery in Your Fingertips, whom we thank for organizing this great event, as well as Dr. Deyanira Capi, Chairman of the ANSI-PN chapter, Dr. Salim Abdul-Raouf, Chairman of the Walter Irandi Neurological Society, Dr. Babak Kateb, Chairman of the Society of Brain Mapping and Therapeutics and Brain Mapping Foundation, all of them Vice President of the organizing committee, and Dr. Parmenides Guadarrama Ortiz, Director of the Specialized Center of Neurosurgery and Neuroscience, Mexico. It's an honor for me to present Dr. James K. Liu. It's a Director of Cerebrovascular, School-Based and Pituitary Surgery at Rutgers Neurological Institute of New Jersey, and Professor of Neurological Surgery at Rutgers University, New Jersey Medical School. He's board certified by the American Board of Neurological Surgery. So thank you, doctor, for being with us. And you can start in the moment that you want.
Okay. Can you enable my screen sharing?
Of course.
Thank you.
It's able now, doctor.
Can you see my slides?
Yes.
Yes.
Okay, terrific. Well, thank you so much, Ahmed, for the kind introduction, and I thank all the organizers for putting on this terrific event, worldwide, international, global neurosurgery at your fingertips. And COVID pandemic has really changed online virtual neurosurgical education, and it's an honor for me to be here and to share with you my topic today. And I want to thank Salim, also old friend and colleague, and all the rest of the organizers, and Jorge Herrera also, who's been in contact with me. So the topic today I'd like to talk about is mastering the temporal bone, and to discuss and describe and to give you the operative pearls of when to use these transpetrosal approaches for skull base and also vascular lesions. When we think about the temporal bone, I think we have to think about being sculptors. And if you've ever had the chance to go to Florence, Italy, you really need to see the Michelangelo David. It's a true work of art, a tremendous piece of sculpting. And when you think about Michelangelo, he kind of had what Professor Roten called having this X-ray vision of the final product, being able to see the structures behind the rock. And the hallway that leads to the David statue are a line of these so-called unfinished works where you can actually see the people being excavated from these pieces of rock. And these are his visions of what the final product will be. And I think when we drill the temporal bone, we have to think about the critical structures that lie deep within, and how can we excavate these structures without injuring them. And so here you can see a picture of the famous landmark Petra in Jordan, where this is much like drilling the temporal bone. You have to find the facial nerve, find the otic capsule, find the jugular bulb. And these are very critical points. When we think about zones to the petroclival region, I've adapted this 4 zones that my friend and colleague Jacques Morcos pointed out to me years ago, is you can divide the clivus into fourths. And the upper fourth arises from the dorsum to the confluence of the Petrus apex. And you can naturally get to this area through an FTOZ or subtemporal approach. And as you get lower on the clivus, between the zone of the 5th and the 7th cranial nerves, the anterior petrosal approach, better known as the Kawasi's approach, really gets you to this area of the petroclival region and also on the brainstem. Between the 7th and 9th, as you go lower on the clivus, you can add a posterior petrosal approach, either use it alone or in combination with the anterior petrosal. And as you get to the lower 1/4, this is generally the lower clivus and foramen magnum, where we treat foramen magnum meningiomas or pica aneurysms, where you can use a far lateral transcondylar approach. And let's not forget the workhorse of most CP angle lesions, which is the retrosigmoid approach. And then more recently, coming in medially, transnasally, endoscopically through a transclival or transpetrous far medial type approaches. So you need to have all of these approaches in your armamentarium, not just endonasal, not just open, but you got to have, you got to be facile in both. So, you know, sometimes you may hear someone say that the transpetrosal or transpetrous approaches are no longer necessary, that you can do everything through a retrosigmoid approach. And while that may be true, I truly believe that transpetrosal approaches remain an important tool in our surgical armamentarium. And when you look at the transpetrosal approaches, it's best to understand it in terms of the anterior petrosal, which is a middle fossa trajectory coming in subtemporally, drilling the Petrus apex, and then cutting the tentorium to get to the posterior fossa and brainstem. And you can come at it from a posterior petrosal approach, which is generally done through a pre-sigmoid transtentorial opening, retroauricular, behind the ear. So there are 2 different types of craniotomies, but you can combine both for larger lesions, and I'll show you some case examples. So the Kawasi's approach is really a middle fossa approach, cutting through the tentorium, getting into the posterior fossa, and then you can access this large window, excuse me, to the brainstem, generally between the 5th and the 7th nerves. And this is great for Petrus apex lesions like cholesterol granulomas, chordomas, chondrosarcomas, some upper petroclival meningiomas. And I also like this for pontine cavernomas that come to the surface anterolaterally between the 5th and 7th nerves. You can also get to the upper to mid-basilar region for aneurysms in that location. And you can also open up Meckel's cave, as you see in this diagram. If you open up the fibrous ring of the porous trigeminus, this really allows access to the Gasserian ganglion and the Meckel's cave medial to the Gasserian ganglion. This approach really gives you this posteral medial angle of attack. So this is a case example of a large epidermoid tumor in the CP angle that I had treated, and I had done this through an extended retrosigmoid approach combined with a far lateral, where I removed the foramen magnum bone to get down access to this lesion. But you could see the lesion was encroaching on the brainstem, and I couldn't really retract this part of the cerebellum. It was causing too much traction on the 7th nerve. So I was left with a residual tumor here. And the best angle of attack to get to this was from an anterior to posterior angle through a Kawasi's approach. So you can combine these with an FTOZ or a combined petrosal with posterior petrosal. And to understand this, you really have to have the positioning of the head correctly. So the common mistake is to position the head completely lateral. And if you look at the surface of the Petrus ridge is pointing away from the surgeon if you're standing looking down subtemporally. What's better is if you rotate the head about 20 to 25 degrees from horizontal, where now the Petrus ridge is more parallel to the floor. So when you're looking down to drill the Petrus apex, the target is closer to the surgeon. If needed, you can also do a drop-down zygomatic osteotomy. This brings the temporalis muscle more inferiorly, so you're flush and there's less temporal retraction. You must preserve the frontalis branch of the facial as demonstrated here. The drop-down zygomatic osteotomy to get down lower. And here's an example of a application we put some years ago, how the temporalis muscle is dropped down even further to allow better access to the Petrus ICA. And so this gives you a more basal trajectory, less temporal lobe retraction, and then you have great access to expose the middle fossa. So how do you navigate the middle fossa without any navigation? Well, you have to understand the middle fossa rhomboid, and also known as the Fukushima rhomboid, that was described by him in 1994 when he was at USC. So you could see that this rhomboid structure is bordered by the back of V3, GSPN laterally, posteriorly by the arcuate eminence, and then medially by the medial Petrus ridge. So if you were to draw and bisect a line down GSPN and arcuate eminence, that would be roughly the angle of the IAC. And just anteromedial to this is the cochlea, also known as the cochlear angle. So here's a cadaveric dissection showing ligation of the foramen spinosum. You must peel the dura propria off of the periosteal layer of the cavernous sinus to expose V3, V2, and you can also need the GSPN runs along the skull base, and I only recommend a posterior direction from traction out of the facial hiatus. In about 20 to 30%, there may be dehiscence of the skull base bone exposing the Petrus ICA horizontal segment, so be aware of this. And then back here is the arcuate eminence. And oftentimes you can encounter what's called a double ridge, where you encounter one ridge, which is not the true ridge of the arcuate eminence, but a false ridge. But you need to dissect even further medially until you see the second ridge, which is the true ridge of the arcuate eminence. And then now you can see where the middle fossa rhomboid is. And just lateral to this is Glasscock's triangle, where you can find the horizontal Petrus ICA. So if we bisect the angle at the Gasserian ganglion, that is the general course of the internal auditory canal, and anteromedial to this is the cochlear angle, where the cochlea resides. So you got to have this X-ray vision of where all these critical structures are as you're drilling the anterior petrosectomy. And generally, you should go from a medial to lateral direction. I generally like to skeletonize the horizontal ICA first, because once you have this identified, you know where the danger zones are, so you can safely drill everything lateral and inferior to the ICA. So once you drill this out, you can skeletonize the ICA. We've left the GSPN intact, and the IAC dura starts to uncover itself, and it looks like a dural fold or a dural sleeve. And there's an anterior component, which is the premeatal space, and then a posterior component, which is the postmeatal triangle. And your inferior limit of drilling anteriorly is the inferior petrosal sinus, and just lateral to the remember that you can mobilize V3 anteriorly, and you'll see more bone of the Petrus apex that can be drilled off even further. This gives you an additional 4 to 5 millimeters of exposure. And then this is the final product from an extradural perspective. And of course, in some cases, such as extensive petroclival chondrosarcomas, you can divide the GSPN and mobilize the carotid and get access to this whole area of the petrous bone below the carotid artery. We published this some years ago when I was a resident under my chief, Bill Caldwell, and you can reference this paper. Exposure of this ICA. This was once used for these Petrus to ICA high flow bypasses for giant cavernous aneurysms. We don't see these cases really these days because most of these lesions have been treated with pipeline flow diverter and vascular stent technology. But this is important anatomy to know nonetheless. When you open the dura down at the base of the temporal lobe and open up the dura of the posterior fossa. You can then cut the dura towards the superior petrosal sinus where it's ligated and then divided sharply. You then cut the tentorium towards the free edge of the incisura. Beware of the entrance of the fourth nerve. This can be easily injured. So you must make this cut behind where the trochlear nerve enters the tentorium. And then this gives you great access to the brainstem, like I had mentioned, between the fifth and the seventh nerves, but you can also get higher up between the fourth and fifth nerves as well. If you angle the scope correctly, you can also access, in some cases, the sixth nerve going into Dorellos canal. Dorellos canal is actually a confluence of venous sinuses where the inferior petrosal and superior petrosal sinuses meet together and join the back of the cavernous sinus. Here's a nice exposure of the basilar artery on this cadaver dissection. And so here's an example of an upper petroclival meningioma, ataxia. You could see that it is a true petroclival meningioma because the tumor is situated medial to the fifth nerve. And here's the positioning supine with a curvilinear skin incision. Frontotemporal bone flap is made. And so here we're going to ligate and divide the middle meningeal artery first at the level of the foramen spinosum. After dividing this sharply, we'll then start to elevate the dura off of the petrous bone, exposing the GSPN, going from a posterior to anterior direction, leaving the periosteal layer on top of the GSPN. We'll then begin to incise and peel the dura propria off of V3. This is the continuation of the temporal lobe dura, forming the lateral wall, the outer layer of the lateral wall of the cavernous sinus. And then we can continue to peel the dura propria off of V3. It sometimes is very adherent here, so you must use sharp dissection with either a knife or scissors. And then what I'm doing here is decompressing the V3 out of foramen ovale first. What this allows you to do is it allows you to mobilize V3 a little bit more freely. So it releases V3. So now we can mobilize V3 and identify the middle fossa rhomboid. So here's the rhomboid. There's the IAC in my mind's eye and the cochlear angle. And we start the petrosectomy from a medial to lateral direction. We mobilize V3 anteriorly, and you can see this is the trigeminal depression, which is a nice potential space that allows you to drill more anteriorly. We've skeletonized the horizontal petrous ICA lateral to that suction. And there is the dura of the IAC skeletonized, and we can now open up the dura, go subtemporally. This is the supratentorial component of the tumor. Under the temporal lobe. This will be debulked with an ultrasonic aspirator. And then we'll peel the tumor away, looking for the free edge of the tentorium. There is a superior petrosal vein that you see there. And then the fourth nerve coming into view. So we have to be careful to preserve the fourth nerve. So we'll go ahead and debulk this mass just so we can get a better visualization of the tentorium. So this completes the debulking of the supratentorial component. And now we'll go ahead and open up the tentorium from either lateral to medial and sometimes lateral to medial. There's the bleeding from the superior petrosal sinus. This is easily controlled with a little bipolar cautery. Sometimes you can inject a little bit of Surgiflow through the lumen. And then we'll open up the posterior fossa dura and then cut the rest of the tentorium to free up this opening. And then we can go ahead and open up and extend the dural opening over the posterior fossa dura, and then open up the arachnoid membranes to get a better exposure of the brainstem. So this is the superior petrosal vein. We'll ligate it as close to the tentorium as possible, preserving the en passage venous flow. And then now we're going to open up the fibrous ring of the porous trigeminus so we can follow the course of the cisternal segment of the fifth nerve as it goes into Meckel's cave. Here's exposure of the tumor in Meckel's cave. So we have great exposure of this tumor medial to the fifth nerve. And this would be difficult to do through a retrosigmoid approach, in my opinion. And I think the beauty of this approach is you have a shorter distance to Meckel's cave, you have great control over the CP angle, and you have great control of both supra and infratentorial components of the tumor. Here we're just peeling the tumor away from the cisternal arachnoid membranes, staying right on top of the tumor capsule and pushing the arachnoid towards the brainstem and neurovascular structures. So there's the basilar artery, there's the brainstem. The tumor is completely removed. The facial nerve and eighth nerve are here and intact in its arachnoid investment. We can reconstruct this defect in a multi-layered fashion with some Duragen, a fat graft followed by Surgicel, and another piece of Duragen. And then we'll use a vascularized pericranial flap that we harvested at the start of the case and rotate it into view. And this gives you a nice reconstruction to avoid CSF leak. Here you can see a gross total resection was performed. She was neurologically intact. Here's another case of a dumbbell trigeminal schwannoma presenting with facial numbness. You can see there's a component in the CP angle, but then another bottleneck component going into Meckel's cave. And so in this case, I chose an anterior Kawasi petrosal approach. This time we did a zygomatic osteotomy to get lower. There is the Petrus apex we're drilling, the middle fossa rhomboid, drilling from a medial to lateral direction.
Okay, good.
And opening up the posterior fossa dura, and then cutting the tentorium to the free edge of the incisura. We'll now open up the porous trigeminus, getting into Meckel's cave. This is the trigeminal nerve. Now in trigeminal schwannomas, you have to try to preserve as many of the trigeminal fascicles as possible to avoid any trigeminal nerve injury and dysfunction. So we'll go ahead and debulk the tumor here with an ultrasonic aspirator. And then here is the seventh and eighth nerves. This is the aica artery. And then we're peeling the tumor away from the brainstem. And then here is the trunk of the fifth nerve. You see how it's wrapped around the top of this tumor going into Meckel's cave. And we have to debulk it. It's rather large, so you don't want to injure and transect the fifth nerve. So it's important to debulk it in a piecemeal fashion so you make the tumor more manageable. And then we could peel the rest of the tumor off and preserve the fifth nerve. Here's the fifth nerve. Here's one branch of it. Here's the other deeper branch. Here's the main sensory trunk, and here's another portion, maybe the portia minor. And here's the final post-op scan. Pre-op, post-op, complete removal. The tumor from Meckel's cave has been removed, and the patient was neurologically intact. Now here's another case. This is the epidermoid case I showed you earlier, where this was a large epidermoid tumor, the CP angle, and lodging itself wrapped around the brainstem, right around the corner of the cerebellum. So a retrosigmoid approach that I had performed was not very adequate. You can see there's the epidermoid tumor. And I did this through a combined retrosigmoid far lateral approach, and there was a blind spot. And you can see there's the 9th and 10th nerves. Here's the 7th nerve. Here's the 5th nerve. And I was able to remove all of this tumor. And unfortunately, this is what I encountered at the end of the surgery. You can see that looks like a nerve that has been transected, most likely the 6th nerve. So if you find one end of the 6th nerve, try to find the other end of the 6th nerve, because and the patient can gain function if you repair it. Now, some have advocated just gluing the two ends together with some fibrin glue, but I generally recommend that this is peripheral nerve surgery inside the skull base. So if you have the two ends of the nerve, you can take a 9-0 or 10-0 suture and just put a single interrupted stitch from end to end through the perineurium, and tie this knot so that you can get the stitch to anchor the two ends together. Now, this is important because once you fill the CP angle cistern with fluid and recharge the CSF, this 6th nerve will flop around and the two ends may not be approximated any longer. So I like to repair these directly with a suture, and then I could put it right on the Petrus bone and put a little Surgicel there so it rests there with some fibrin glue. So there's the 6th nerve. This is a view with a 30-degree angled endoscope, and here's the lower cranial nerves. There's 7, and here's 6 repaired. Okay, so we were able to repair the 6th nerve, but there's residual tumor, like I mentioned, right in the blind spot. And here she is at 4 months. You can see the nerve is starting to come back at as early as 4 months post-op. And here's the patient at 7 months post-op. The 6th nerve is completely resolved. She's able to lateralize that right eye all the way to the right. Unfortunately, the tumor continued to grow at 9 months, and now my hand was forced to go back and remove the rest of this residual. And the choice of approach here was to come through a Kawasi approach. And here they had right-sided Kawasi's approach. And I extended it to do a mid-petrosal binded, the posterior petrosal. Here's the semicircular canal, posterior canal, superior canal, lateral canal. There's the IAC. And this allows me to open up the dura more posteriorly and then more inferiorly, and I can cut out the whole tentorium to visualize the whole cerebellum. So here's the 4th nerve coming from a middle fossa perspective. And then here's the 5th nerve that's been displayed on stretch. And then here's the view of that top of the cerebellum where the tumor is lodged. And then I can peel all of that tumor looking straight back at the brainstem. And I could see the root of the 7th and 8th nerves being displaced. This is an area that I wasn't able to see with a retrosigmoid. And coming from a Kawasi's approach, I can look right at the back of the brainstem and peel the tumor away and spare 7th and 8th and preserve them. And here's a nice view of 7 and 8. Here's the basilar artery. And then this is the 6th nerve that's completely healed and recovered. And then looking superiorly, there's the 5th nerve and the 4th nerve. So you have a nice panoramic view of all of the cranial nerves and a gross total resection. And this patient ended up doing great. Petrus apex granulomas. This is an excellent approach for Kawasi's. I do like to do these endonasally for the most part, but the endonasal approach here is limited. The reason is because look at the prepontine cistern highlighted in white, and look at the paraclival carotid artery highlighted in red. So the window, the corridor to drain the cyst is quite narrow. It would be easier to come from a middle fossa approach. This is a paper I once wrote as a fellow of Dr. Deleshaw. And you could see he has described this technique using a catheter that goes into the Petrus apex cyst. And then if you drill a hole between V1 and V2, you'll get access into the sphenoid sinus, and you could thread the ventricular catheter into the sphenoid sinus to drain the cyst. Now we took it up a notch and added a second catheter that went from the cyst into the mastoid cavity where it can drain into the middle ear. This is what we call the double exhaust technique. And we're now going to elevate the temporal lobe dura extradurally and divide the middle meningeal artery at the foramen spinosum. So in order to do this technique, you have to stay extradural and you cannot get a CSF leak. Otherwise, you're going to end up having CSF leakage through the nose. There's the GSPN. You can see the GSPN coming into view. There's the GSPN dissecting from posterior to anterior. And then you can now see the brown colored cholesterol cyst. And so we're going to peel the temporal lobe dura off of the top of the cyst. And eventually we're going to enter the cyst, and you can see the fluid contents of the cholesterol cyst with a lot of cholesterol crystals that you can see. This is typical material from these Petrus apex granulomas. And that's the cyst wall adherent to the posterior fossa dura. So that cannot be removed, but the lateral cyst wall can be safely resected. And all of the posterior fossa dura that used to be compressing the pons is now reinflated. So that is restoration of the CP angle cistern. It's like a water bed that's been decompressed by removing the compression. And now we'll go ahead and drill the hole between V1 and V2, and we're going to access the sphenoid sinus. Here you can see the sphenoid sinus coming into view, that dark hole, and then we'll thread the ventricular catheter into the sphenoid sinus, and then the two catheters from the cyst going in the sphenoid and also the mastoid. So this is the double exhaust drainage method. And here's the final view. You could see post-op, nice decompression of the brainstem. And this cyst has not recurred in 10 years. So we have 10-year follow-up, no recurrence. Facial nerve came back to normal hearing, excellent result. Here's the pre-op, post-op, no recurrence in 10 years. So let's change directions a bit. That was the anterior petrosal. So what is the posterior petrosal? The posterior petrosal is a pre-sigmoid window of exposure that usually combines a supratentorial, temporal, parietal, occipital craniotomy with a mastoidectomy. And the idea here is that you need to completely unroof the sigmoid sinus so that you can mobilize the sigmoid sinus posteriorly to increase this window of exposure. This is an illustration from Professor Al-Mefdi that he calls the double martini, the double petrosal approach. You can see we can spare the otic capsule and the hearing, and to get this wide exposure, having multiple angles of attack. This is an example of a combined petrosal I used on this recurrent brainstem cavernoma. This patient had a prior retrosigmoid and a prior endoscopic endonasal transclival approach to this cavernoma at an outside hospital. Unfortunately, there was residual cavernoma and he kept bleeding, and he presented with left 6th, 7th, and 8th nerve palsies and right arm and leg weakness. And so this thing was getting bigger, and I felt this would be best approached through a combined petrosal. You can see the yellow arrows, the trajectory of the Kawasi's approach, anterior petrosal, because it comes right to the surface there. Now, on these cavernomas, pay attention to the bright signal. This is a deep venous anomaly coursing right through the middle of the brainstem. You have to preserve this vessel, otherwise you'll have a brainstem infarct. So we took the previous retrosigmoid incision and extended it anteriorly to get a large combined petrosal approach. We harvest a large pericranial flap. And then I generally like to perform a temporal craniotomy and combine it with an extended mastoidectomy that exposes the retrosigmoid dura. So we published this video recently, and now we're elevating the temporal lobe dura from the GSPN, going from posterior to anterior. We're going to ligate the middle meningeal artery and divide it sharply and peel the dura propria off of V3. You can encounter venous bleeding from the cavernous sinus, which is easily controlled with a little Surgiflow and gentle packing. We'll then go ahead and open up the Petrus apex, drilling out the Petrus apex from medial to lateral. Here's the horizontal Petrus ICA. And then I'm going to move towards the mastoidectomy and perform a retrolabyrinthine mastoidectomy. This is the mastoid antrum, where you can identify the lateral semicircular canal and the incus. And then we skeletonize each of the semicircular canals. They're all orthogonal to each other. So you identify the posterior and superior canals and the common cruce. This is the otic capsule. And then now that you've identified the posterior canal, you can hug the dura and drill the bone in that retrolabyrinthine space and then combine it with the anterior petrosectomy. This gives you a nice wide exposure. We'll then open up the dura along the base of the temporal lobe. Be careful of the veins of Lebet. We elevate the free edge of the tentorium to look for the fourth nerve, and then we'll open up the rest of the temporal lobe dura and the posterior fossa dura of Kawasi's triangle. And then we're going to meet ourselves at the superior petrosal sinus, the SPS. You can see the venous bleeding from the SPS is carefully coagulated with a bipolar. And now we'll elevate the free edge of the tentorium and look for the fourth nerve. There's the fourth nerve. We're going to cut behind the entrance of the fourth nerve so we don't injure it. And then there's our exposure. You see how the fifth nerve is being pushed towards us? We'll then open up the arachnoid membranes over the fifth nerve and identify the brainstem. And then here I tried to open up the pre-sigmoid dura, but there was significant scar tissue because of the previous surgeries. So I attempted to remove everything through the Kawasi's corridor. And there's the exophytic portion of the cavernoma. You can see it's emanating out of the brainstem, and we'll define a plane to follow it into the brainstem. And we use neuromonitoring with motor evoked potentials, SSEP, and facial and ABR monitoring. Here we're using a little gentle traction with suction dissection to get the cavernoma free. And this is removed in a piecemeal fashion. Keep in mind this patient had a large deep venous anomaly medial to all this, so we have to be careful of that structure. And so there's removal of the cavernoma. And then there's some more hemosiderin stained areas. And if you use image guidance, this allows you to find the rest of this cavernoma. Now, when you do a recurrent cavernoma that's been operated on, sometimes there can be seeding where you have more than one in the same region. And so this is what we encountered here. This is a safe zone of the brainstem, just medial to the fifth nerve, so we can make our corticectomy a little wider to get better access to this residual cavernoma. And then there's the cavernoma being dissected from the white matter. There was a lot of scar tissue, which is very adherent because this had been previously operated on. So I generally use sharp scissor dissection here. And then we'll go ahead and peel the rest of this cavernoma away. Working above and below the fifth nerve. So there's the deep venous anomaly. I confirmed it with image guidance. And then we can put an endoscope in here and look around corners. We can look inside the resection cavity. There's the fifth nerve. And I didn't see any further residual. I did see the deep venous anomaly there. There's the fourth nerve, and complete removal, and then multi-layered reconstruction. You have to occlude the entrance to the middle ear so you don't get CSF rhinorrhea. I usually use a layer of wax followed by some bone cement, and then multi-layered fascia lata, Surgicel, and then a vascularized pedicled pericranial flap. And then here's the post-op CT scan showing the double petrosectomy, preserving the otic capsule, preserving the hearing. And here's the pre-op MRI. There's the post-op MRI, complete resection. And the patient had complete resolution of the cranial nerve palsies and regained a significant amount of strength on the right side. And he's now ambulating. This patient is now a motivational speaker and has recently written a book. The combined petrosal approach I like to use for these large petrotentorial meningiomas, petroclival meningiomas. And here's the large C-shaped incision, lateral positioning. Again, vascularized pedicle pericranial flap, and then a temporal craniotomy with an extended mastoidectomy to include the retrosigmoid dura. You can find this video on YouTube, published in Skull-Based Operative Videos. Here's the otic capsule that's been dissected. So we're drilling out the anterior petrous apex now, and then we'll open up the dura along the temporal lobe. And then we'll go ahead and ligate the superior petrosal sinus, open up the presigmoid dura, and then here we're ligating the superior petrosal sinus, this time with a suture ligature, using a 2-0 silk stitch. And then we can go ahead and start cutting the tentorium. And as we cut the tentorium, look how it opens up the view to the top of the tumor. And then there's the 7th and 8th nerves below the tumor. That's the inferior margin of the tumor. But when we cut the tentorium, we're able to look at the tumor from above and also from below and from behind. This is the advantage of having this combined petrosal approach as opposed to a pure retrosigmoid approach working in a narrow corridor. I can cut the rest of this tentorium towards Meckel's cave as this tumor extends towards Meckel's cave, as you can see. And then go ahead and debulk the tumor using an ultrasonic aspirator. Now we're working underneath the 5th nerve. And then peeling the tumor away from the brainstem. And there's the final dissection of the tumor away from the 7th and 8th nerves, peeling the tumor away from the brainstem here medially, preserving the arachnoid membranes. You want to stay between the tumor capsule and the tumor and cisternal arachnoid membranes. And then here's an endoscopic view of the resection cavity, complete removal. And I like to use this fasciolata sling to repair these presigmoid defects. We published this some years ago. And this allows us to make a little hammock or a sling, and you can rest the fat graft on top of this. And then this is the publication showing how we do this for translab approaches for acoustics, but you can also do this through presigmoid petrosal approaches as well. And then here's an example. Here's a glomus tumor, transjugular approach, big transsigmoid dural defect. Here's the fasciolata sling, and then the fat graft on top. And then you could bolster the fat graft with the bone plate and the cranioplasty plate with a MedPore Titan implant. So here's the post-op scan showing the double petrosectomy. And here's the immediate post-op MRI, complete removal. And then here's the delayed 3-month MRI. You can see nice decompression of the brainstem, and the patient got her gait function back, neurologically intact. Here's an example. This is a video we just published in Operative Neurosurgery. You can find the links on my Facebook and Twitter sites. I just posted it today. This is a large trigeminal schwannoma compressing the brainstem, extending into Meckel's cave. And then here is the combined petrosal approach that we used. So there's the posterior petrosectomy, otic capsule, and Kawasi's anterior petrosectomy. We're going to open up the dura in a pre-sigmoid fashion, and then open up along the temporal base, and then coagulate the superior petrosal sinus. You have to preserve the veins of Lebet back here, and they're protected underneath the patty. And we'll go ahead and open up the arachnoid to release CSF. This will give us brain relaxation. Here's the tumor compressing the brainstem. There's the trigeminal nerve. There's the trigeminal nerve again. We're going to stimulate it to make sure the facial nerve does not stimulate. If you're monitoring the facial nerve, be sure to monitor the masseter muscle, because that's the trigeminal nerve. So that confirms it's the trigeminal nerve. There is the brainstem, and we'll continue to peel the tumor away from the brainstem. Now you can see the 7th and 8th nerves coming into view, which is on the inferior margin of the tumor. And as you decompress the tumor, it allows the tumor capsule to collapse. So you can easily peel the tumor away from the 7th and 8th cranial nerves. And my philosophy is that if you have tumor that's adherent to any of these critical nerves, you should better to leave a small residual on the nerve than to have the nerve come with the tumor into your specimen. So you want to avoid cranial nerve palsies as much as possible. We're going to cut the rest of the tentorium to the petrous apex, and then we're going to look under the temporal lobe here, and here's Meckel's cave. We're opening up the dura into Meckel's cave. This is the porous trigeminus. Here's the tumor going into Meckel's cave. And then we'll debulk the rest of this tumor medial to the 5th nerve. And then here's the rest of the tumor that's more anterior, compressing the brainstem. And the last structure we haven't seen yet is the 6th nerve. And so we have to be aware of the 6th nerve, which is going to be more medial to the tumor. And then there's the branch coming off the basilar artery. And here's the final peeling using these nice delicate micropatties to protect the brainstem in tight, narrow spaces. There's the basilar artery. There's the 6th nerve. Small little residual adherent to the 6th nerve that I left intact. So this was a near total removal, about 99% removal. I like to use the endoscope to look inside the resection cavity to look at all the structures. There's the 7th and 8th nerves, 5th nerve. And then the closure is the fascia lata sling, using cement to occlude the entrance to the middle ear, and then using the fat graft on top of the sling with a vascularized pericranial flap. And here's the pre-op scan above. Here's the post-op scan below. Nice decompression of the brainstem. I like to use these petrosal approaches for some deep-seated AVMs. This is a deep petrosal cerebellar AVM. It's on the petrosal surface, almost right at that petrotentorial junction. This was angiographically fed by distal SCA feeder. So I felt that I would have better control of the distal SCA through a lateral approach as opposed to a small keyhole retrosigmoid approach. So I like to take these 3D angiograms and rotate them into the surgical view. Here's the incision, petrosal approach, the vascularized flap, and we'll do a temporal craniotomy with a retrolabyrinthine petrosectomy combined with an anterior petrosectomy. There's the otic capsule. And then we'll go ahead and open up the dura, go subtemporally, and then presigmoid. And now we'll open up the arachnoid membranes. Look how the exposure takes you right on the deepest part of the cerebellum. There's the brainstem. Here's the SCA vessel. And then notice the cerebellum has a yellowish tinge. This is hemosiderin staining. And pay attention to this vessel here. This is an arterialized vein. And watch how this vein turns blue after we coagulate this feeder. And now it turns blue. And so we'll make a corticectomy right over this region to find the AVM. And this is not a big AVM, it's a micro AVM. Sometimes they can be difficult to find. But with image guidance and paying attention to the tissue planes, you can see the small micro vessels coming into view. These are abnormal small AVM vessels, and just using standard traditional cautery technique to stay around the periphery of the AVM, taking the small feeders that are going into it and dividing them sharply, and then looking for that white matter plane around the AVM. You can see the AVM is eventually charred and removed, and here's the final view. And here's the post-op angiogram, no residual AVM. And so briefly, the variations to the posterior petrosectomy can be performed based on how much bone you removed and based on the hearing status. So here's a diagram from, this is one of Dr. Delashaw's previous publications. You can pay attention to this area of the otic capsule. And what we're gonna do is we're gonna take, we'll go from a retro lab and we'll take out the superior and posterior canals. This is what's called the Transcrucial Approach. Dr. Shekar has called it the PLPA, partial labyrinthectomy, Petrus apicectomy, but generally removing these two canals. And if you wax the semicircular canals as you're removing them and try not to lose the endolymph, you can potentially preserve hearing. But it gives you more exposure. Of course, you could do a translab that gives you more exposure to the petroclival region. And then the big approach is to transpose the facial nerve posteriorly and drill the cochlea, which is a transcochlear approach. And this gives you the widest exposure to perform essentially a total petrosectomy. So here's a rodent cadaver dissection showing the semicircular canals. If you remove the superior and posterior canal, you get wider exposure. Here's a deep magnified view of this, of the basilar trunk. And then you can skeletonize the facial nerve from the fallopian canal to the geniculate ganglion, divide the GSPN, and then mobilize this facial nerve posteriorly. You have now this complete access to the cochlea, and you can do a transcochlear approach. But we have largely shied away from this approach because mobilizing the facial nerve generally results in facial nerve palsy post-op that recovers to only a House-Brackman 3. So only in rare instances do we do this. It's very rare to perform this. This is the diagram showing the PLPA, transcrucial approach, removing the superior and posterior canals and plugging it with bone wax. Here's another diagram showing the view of the increased exposure to the petroclival region. And here's an example where I used that transcrucial approach. This was a large petroclival meningioma. The tumor is extending into Meckel's cave, but look at this angle of the tumor compressing the brainstem. If I did a retrosigmoid approach, there would be excessive retraction of the brainstem as well as the cerebellum to get to this tumor. I like to come in petrosal. It's essentially retractorless, and you can see here's the post-op scan. I left a very microscopic adherence to the trigeminal rootlets in the Meckel's cave. And then this was a nice decompression of the brainstem. Hearing was intact. Here's an example of a middle fossa meningioma extending into the infratemporal fossa. This was treated by another colleague of mine back in 2007. There was residual tumor left along the course of the Petrus ICA. This was treated with radiosurgery by my colleague. And you could see after a few years, the tumor continued to progress. It was encasing the ICA and now invading the facial nerve and jugular bulb. The patient had a complete facial nerve palsy. So my plan was to do a total petrosectomy transjugular approach with facial nerve grafting. She had a balloon test occlusion, which she passed. So the tumor was encasing the ICA. So I sacrificed the Petrus ICA. I didn't do a bypass and she passed her balloon test. And then I opened up the jugular bulb, resected all the tumor invading the jugular bulb. And here's the final view. This is the entire infratemporal fossa. These two clips are the two ends of the Petrus ICA. Here is the sixth nerve. And then her facial nerve I repaired. This is the two ends of the facial nerve. This is the fallopian canal segment. This is the brainstem segment. We use a sural nerve interpositional graft sutured in with 9-0 nylon sutures. And then here you can see total petrosectomy bony defect with reconstruction of the middle fossa using a gull wing technique. And then here's the post-op scan, complete removal. And then you could see the course of her facial nerve recovery. She started with a Brackman 6 and she ended up with a Brackman probably 2.5 in my opinion, but a very, very nice result for her. And lastly, I want to share with you another application of the transpetrous approaches, and this is for jugular foramen tumors like glomus jugulare tumors. These are tumors that are in the jugular bulb. You do an infralabyrinthine mastoidectomy combined with a cervical neck dissection. This is Taka Fukushima's technique we published some years ago in the Red Journal. Here's the infralabyrinthine mastoidectomy. Facial nerve is skeletonized, high cervical region exposed. You can get exposure by doing a combined intradural exposure if the tumor goes intradural. But the key is to preserve this medial wall of the jugular bulb in order to preserve lower cranial nerve function if they are still intact preoperatively. Here's an illustration in Al-Mefdi's atlas showing a paraganglioma of the jugular bulb extending into the middle ear, and you can see opening up of the jugular bulb. And if you preserve this medial wall of the jugular bulb, you can preserve these lower cranial nerves. So this is an important step. I'll show you one case. This is a 51-year-old male. You can see he has winged scapula. So when you have winged scapula, that's likely a 11th nerve palsy, spinal accessory nerve palsy, but you can get it also from a long thoracic nerve palsy and a dorsal scapular nerve palsy as well. Hemiatrophy of the tongue, a mass in the back of the mouth. So you have to think about, this looks like Vernet's syndrome. Vernet syndrome with cranial nerves 9 through 12 palsies. Here's the imaging showing this lesion, T2 bright signal compressing the brainstem. This is a large giant chordoma of the jugular bulb going into the parapharyngeal space and lower CP angle compressing the brainstem. The patient already has complete lower cranial nerve palsy. He has trouble swallowing, and he's malnourished. He's not eating any food. So we went in and did a stage 1 tracheostomy and peg tube to optimize his nutrition. And then we come in through a lateral skull base approach, transjugular approach. Here you can see the tumors eroded the clivus and also the occipital condyle. So he has an unstable occipital cervical joint that needs a fusion. So we come in through this infratemporal transjugular approach. And now we've opened up the mastoid. There's the sigmoid sinus. We're skeletonizing fallopian canal. Here's tumor completely eroding the occipital condyle. And now we'll skeletonize the V3 segment of the vertebral artery. There's the vertebral artery. And now we're going to skeletonize the facial nerve off the fallopian canal. This is a fallopian bridge technique where we work in front and behind the facial nerve. There's the internal jugular vein that we're tying off. And then we'll open up the sigmoid sinus and plug the sigmoid sinus proximally using an intraluminal gel foam technique. And then we inject Surgiflow distally to plug the back bleeding from the inferior petrosal sinus. So this allows you to have a bloodless opening of the jugular bulb. There's tumor, chordoma tumor in the jugular bulb. And now we're gonna go into the neck. This is the tumor that's in the parapharyngeal space. The carotid arteries are being retracted posteriorly, and we'll debulk this tumor in the neck, follow it to the jugular foramen. And now we can focus on the occipital condyle. This is the remnant of the occipital condyle. We're gonna drill the rest of this off. That exposes more chordoma at that C1, C2 space. This is the bottom of the clivus that's being drilled. The clival defect that you saw that was eroded by the tumor. And now this is the tip of the odontoid. This is the odontoid process. We're right at the tip of the odontoid. We're gonna drill the rest of this tip of the odontoid off and resect all of that tumor that's wrapped around the odontoid peg. We'll go intradurally, find the ipsilateral vertebral artery that you see here and debulk the tumor away from the vertebral artery, protecting it. These are the lower cranial nerves that are now completely dysfunctional, so we can safely divide them. And then resect the clival dura where this tumor is arising from. There's the clival dura, and there's the vertebral basilar junction and brainstem. So we have a large dural defect we have to repair. We'll use a multi-layered repair with an alloderm sutured into the defect, and then we have to plug the middle ear so you don't get CSF leaking into the middle ear. We'll use a fat graft for the dead space and bolster it with a Medport Titan plate. And so here's the pre-op scan, here's the post-op scan, complete removal, and a third stage occipital cervical fusion done at a later date. within a few days. And here's the patient at follow-up, doing great, and referred to proton beam radiation therapy. So in conclusion, I truly believe these Transpetrosal approaches remain important tools and strategies in our armamentarium as a skull-based and vascular neurosurgeon. Sometimes they can provide a more advantageous angle of attack to the brainstem or to your desired target. And you must master the temporal bone like an artist and archaeologist. And again, I thank you for this opportunity to share this information, and I'll be happy to take any questions at this time.
Thank you, Dr. James Liu, for your amazing presentation. It's amazing how you do this neurosurgical techniques. And we have a pair of questions only. The first one, what will be the best size for the temporal craniotomy?
What is the best size of the temporal craniotomy? I think you have to make it wide in the AP direction, anterior, as anterior to the root of the zygoma. Maybe I generally say a few centimeters anterior to the root of the zygoma, but you have to make it a little more posterior, close to the transverse sigmoid junction. And then you only need to make it as high as the distal sylvian fissure. You don't have to make it too high, but you want to make it a little bit close to where the superior temporal line is sitting. So that's generally where I like to make it.
Okay, thank you, doctor. There is no more questions. So I thank you on behalf of the organizers of this World Congress for giving us your time and sharing your knowledge with us. Thank you very much, doctor.
Okay, thank you very much.
Thank you very much, Dr. James. It was great for your presentation and very, very illustrative. Thank you for your time. Y le recordamos a todos a los que nos están observando, que nuestra siguiente ponencia será